My name is Jonathan Martin. I'm a lifelong Rhode Islander, a URI graduate, a Penn State Medical School alumnus, and a Roger Williams Hospital residency graduate. I began practicing primary care in 2011 in Rhode Island, launching my career in a thriving private practice setting in northern Rhode Island. We had 10 providers and saw 130 patients daily, offered same-day sick visits, welcomed new patients within the week, and maintained strong communication with hospital colleagues and specialists. Practicing medicine was rewarding, and our practice buzzed with high morale. Patients were satisfied, forming deep bonds with entire families often. Our loyal staff consistently went above and beyond to ensure exceptional care. Early on in my career, the landscape seemed to shift. Insurance companies tightened their grip on our practice, demanding extensive patient data, constant information streams, and enrollment in programs. These uncompensated tasks consumed our staff's time. Many initiatives, often branded under things like value-based care, failed to deliver measurable improvements in patient outcomes or cost efficiencies, and instead drove up health insurance premiums. Our practice, stuck with stagnant revenue, juggled patient care alongside the insurance company's administrative demands. As their requirements grew, reimbursement rates remained flat. Larger insurance companies, bloated with programs and overhead, raised premiums, yet none of that revenue reached our practice. We were buried in unnecessary paperwork, demoralized by frequent denials, and disheartened by stagnant wages for providers and staff. Eventually, the financial margins became unsustainable, and with our spirits strained, we were acquired by a large corporation. We hoped that this would alleviate the challenges of running a private practice under the insurance dominance, proving the promised improvements in outcomes and efficiencies. Instead, we encountered an even worse version of that same wasteful, misguided approach. Staff grew despondent, leadership was non-existent, and responsibility was deflected in every direction. Our bosses, based in New Jersey and Chicago, stripped us of autonomy. We couldn't even decorate our office as we wished. Morale plummeted, wages stagnated or dropped, and we faced layoffs in the office, surging work absences, and stress-related disability claims. Providers left for the neighboring states or beyond, and staff turnover soared. Patients felt the loss of the familiar faces in the office, with new unfamiliar receptionists that had high turnover, new assistants, and new providers. The sense of family had vanished. Insurance companies and their corporate allies had turned our community-focused, professionally licensed service into a national commodity, plunging us deeper into a state of despair. When my corporate contract ended, I joined a large hospital system for 1 year. Loyal patients followed me, but they sensed the decline in care quality. Access was limited, staff and providers were disconnected, and leadership seemed to remain absent. It was an improvement over corporate control, but it paled compared to the private practice that we once knew. The burden of data production and paperwork only intensified. Bent but not broken, my colleague Dr. D'Alessandro and myself resolved to revive our private practice, aiming to restore the work environment that we had once cherished. 1 year ago, we reopened. We've grown from 2 to 11 providers and from 4 to 42 staff. Many are familiar faces from our earlier practices, warmly remembered by our patients, joined by new team members who share our passion for quality primary care. Our office feels like family again, and patients notice. As our own bosses, we answer calls, we return messages, we offer same-day sick visits again, and we see patients within the week. Yet, the insurance burden is heavier than ever. We prioritize patient care even when it conflicts with the insurer's demands, having witnessed the waste and lack of evidence for improvement and the greed that has been fueling that system. Worse still are the restrictive contracts that bind us like chains. Reimbursement rates remain nearly at 2017 levels, some lower, while practice expenses, rent, electricity, labor costs have all nearly doubled. We've lost talented doctors and nurses who've given up or relocated. Despite our resolve, after a year of remarkable growth, unmatched service, and superior outcomes with happier patients than any of our prior corporate endeavors, we are in debt. We're fortunate to have reunited loyal staff and dedicated colleagues, but without immediate change, we risk stalling and failing under this insurance model's uncompensated work and restrictive contracts. We've seen large practices collapse in the state, leaving tens of thousands of patients without care. We've appealed directly to insurance companies, only to face uncompromising rejection. We urgently need relief from the chains imposed by these companies. The first step is ending their ability to lock us into these restrictive contracts. As their profits soar and premiums climb, our practices shrink, and our patients receive less care, not more. Private practice primary care is the cornerstone of a functioning healthcare system, the only model that has truly worked. We must preserve practice's ability to survive in Rhode Island and attract new physicians and nurses to the state. Rebuilding community-focused, patient-centered practices requires robust support for private practice. Because of this, I am in full support of this bill. It is the first step in freeing physicians from the overburdensome rules of insurance companies and bringing quality primary care back to the patients of Rhode Island. This bill will allow our practice, and many like it, to continue to operate while preventing catastrophic closures such as we have seen recently in the state. This bill further helps prevent the already rapid movement of physician practices into direct primary care or concierge medicine, models which cost patients thousands of dollars per year and reduce access by significantly limiting patient panels. This is but a step in the right direction, but a step that is desperately needed immediately. Thank you for your time.